Okay, in these next 3 slides, we will be talking about cardiogenic shock. So, in the physical examination, a characteristic of patients with this type of shock, patients appear ashen or cyanotic and have cold mottled extremities, peripheral pulses, and rapid and faint. It may be irregular if arrhythmias are present. Jugular venous distension with crackles in the lungs may be present, not always, and then peripheral edema. Heart sounds may be distant, and third or fourth heart sounds may be present. Pulse pressure may be low, and patients are usually tachycardic. Patients show signs of hyperperfusion, such as altered mental status and decreased urine output. Signs and symptoms: it's sustained hypotension, systolic blood pressure of greater than 90 for more than 30 minutes, reduced cardiac index of 2.2 liters per minute, presence of normal elevated PCWP. Pulmonary capillary wedge pressure. Images include echocardiography performed early to establish the cause of cardiogenic shock. Ejection fraction can be estimated with this procedure as well. An ABG for cardiogenic shock typically reveals severe metabolic acidosis with elevated lactate levels and a significant base deficit, reflecting tissue hypoperfusion, may also show hypoxemia and mixed venous O2 saturations. Studies for these type of shock include biochemical profiles, so parameters of electrolytes, renal function, urea, creatine levels, liver function, AST, ALT, LDH, assess proper vital organ function. CBCs are helpful to exclude anemia, cardiac enzymes to diagnose acute myocardial infarction, serum markers including CK, troponin, myoglobin, and LDH. Troponin is a cardiac troponin T useful to diagnose a myocardial infarction. ABG can indicate overall acid-base hemostasis and levels of arterial blood oxygenation. Lactate levels that are elevated indicate shock. Brain neutropenic peptide BNP may be useful as an indicator of CHF. Low levels of BNP may effectively rule out cardiogenic shock, but in the setting of hypotension, however, elevated BNP level does not rule the disease. These are a couple images, EKGs of patients in cardiogenic shock. So the first image shows evidence of an extensive anterolateral myocardial infarction. The patient subsequently developed cardiogenic shock due to the damage of the heart, so the heart was unable to pump the blood through the cardiovascular system. The other one is also an EKG tracing further evolutionary changes in a patient with cardiogenic shock, just how much more damaged the heart is and how much more the heart is struggling throughout that process. Pharmacology. So patients with MIs are given heparin and aspirin to thin out the blood in order to kind of help the flow and the pressure of moving that blood throughout the body. Glycoprotein inhibitors improve patients with a non-ST segment elevation, ACS. They avoid beta blockers in patients with signs of heart failure or low output states. However, initiating beta blockers may be reasonable for patients who are evolemic or off inotropes and vasopressors for a minimum of 24 hours. Initiating statins with patients with cardiogenic shock associated with myocardial infarction. Statins are medications that help the heart. So those are known as like atorvastatin, which is a Lipitor, rosuvastatin was Crestor. They just kind of help the heart move that blood around. Monitoring for this kind of shock, it's very invasive. Hemodynamic monitoring, so a Swan Ganz catheter to measure your CVP, your pulmonary arterial pressure, and your pulmonary capillary wedge pressure, just to see how much the heart is working. Is very helpful to help exclude other causes and types of shock. your pulmonary capillary wedge pressure of greater than 15 mmHg and a cardiac index of lower than 2.2 liters per minute. Presence of large V waves on the PCWP suggests several mitral regurgitation. Mechanical ventilation for cardiogenic shock is frequently required to manage severe respiratory failure, reduce work of breathing, and improve hemodynamics via positive pressure, which lowers cardiogenic preload and afterload. Non-invasive ventilation increasingly used as a first-line option to avoid intubation. So we try to use CPAP, BiPAP, high flow before we jump into mechanical ventilation. But when that is the choice, PEEP is used to improve oxygenation, but should be carefully titrated to balance oxygenation against decreasing cardiac preload. Lung protection, with that one, they use low tidal volumes to help prevent lung injury.